Good morning, everyone. I'd like to thank the Facial Pain Association for the opportunity to present my experience on the use of radiation treatment for facial pain. My name is Stephen Chang. I'm the Robert and Jeanette Powell Professor of Neurosurgery at Stanford University School of Medicine, and I've been actively treating patients with facial pain and trigeminal neuralgia for the last 20 years. In terms of procedural treatments for trigeminal neuralgia, we're going to hear from a variety of speakers today about the various different options. And here's a list of the most common options. I think that there will be extensive discussion on microvascular decompression, so I'm not going to discuss that. I'm going to focus my presentation for the next 30 to 45 minutes on stereotactic radiosurgery for trigeminal neuralgia. I do want to say that I do think that for the majority of patients, I feel that microvascular decompression is the ideal treatment. And over the course of my talk, I will outline which patients are candidates for radiosurgery. So the first question comes up is how does radiation work for trigeminal neuralgia in the first place? And I think the actual mechanism is unclear, but we do know that the radiation seeks to injure the pain fibers of the trigeminal nerve. I like to describe to patients the trigeminal nerve as like wires in a cable, and the trigeminal nerve has wires that control pain and wires that control sensory function, such as light touch or temperature. And when we deliver radiation to the trigeminal nerve, we're attempting to injure and destroy the pain fibers in the trigeminal nerve, but try to keep the other fibers, such as touch and temperature, intact. In terms of the various machines that can deliver radiation for trigeminal neuralgia, the two most common machines are the Gamma Knife and CyberKnife. Both have the same basic functions in that they deliver beams of radiation precisely and accurately to the trigeminal nerve to achieve the results. The Gamma Knife was the first machine used to deliver radiosurgery for trigeminal neuralgia. It involved a rigid fixation of the head and involves the use of cobalt-60 as the radiation source. The CyberKnife was invented in the early 1990s, largely as a option to overcome some of the limitations of the Gamma Knife, in that we could then treat lesions that needed fractionation, or we could treat patients who did not want to have the rigid external frame placed on their head. So the CyberKnife is a compact linear accelerator. It uses image guidance to take pictures of the patient's position and adjust for any patient's movement during the treatment. It is image guided in the sense that it uses these pictures to track the patient's position. The linear accelerator is mounted onto a robotic arm and moves around the patients to deliver the radiation. These are the two areas where it shows how the patients are positioned for each of the two treatments. On the left side, you will see a patient undergoing CyberKnife treatment. We use what's called an Aquaplast mask. It's a plastic mesh mask that is form-fitted for the patient. This immobilizes the patient and prevents large amounts of movement. Any additional movement is tracked by the machine and allows the machine to maintain a high degree of accuracy during the treatment. On the right, we'll see a picture of a patient being prepared for a Gamma Knife treatment. The head is immobilized in a rigid external frame, and this allows the radiation to be delivered accurately. This is a picture of our CyberKnife machine. I'm going to just briefly focus on this because this is the type of technology we use at our institution at Stanford to treat patients. So the machine consists of a linear accelerator, which is a box that is placed on the robot. This is the linear accelerator right here. There's a robotic arm which attaches to the floor here that moves the linear accelerator around the patient. There are imaging cameras in the ceilings right here that take images of the patient position during the treatment. And then there's targeting software that allows us to track and compensate for any patient motion during the treatment. So in terms of the how we actually target the trigeminal nerve, we still rely on a thin slice MRI scan. So this is a typical MRI scan that we will obtain on a patient. And a thin slice typically means approximately 150 slices through the head of the patient. And this allows us to obtain information about the brain anatomy in high detail. And on this slice here, we can see this patient has a trigeminal nerve on the left side here, and we can actually see a blood vessel impacting the nerve. So these MRI scans are used in preparation for the delivery of radiation. We also obtain thin slice MRI scans if we're considering a patient for microvascular decompression in order to understand the anatomy around the trigeminal nerve and to determine if there are any blood vessels that are present. So how narrow is a radiation beam when we talk about radiation for trigeminal neuralgia? Typically, the beams that deliver radiation are on the order of about 4 to 5 millimeters in diameter. And on the left side here, we can see a rough approximation. An eraser on the tip of a pencil is about a 5 millimeter diameter, with the tip of a pencil being 1 millimeter. On the left side here, we see a treatment plan for a patient. And each one of these lines represents a beam coming in from a different angle around the patient. And they all coalesce and combine to deliver the total radiation to the trigeminal nerve. This is an actual trigeminal nerve treatment plan, and I wanted to present this to show how we actually target the radiation. So this is a close-up, it's a zoomed view of the MRI scan. And on this sequence here, we see the brainstem is this structure here, and the trigeminal nerve is the gray line here. This white is the cerebral spinal fluid. It's the fluid that surrounds the brain and the spinal cord and cushions the brain and the spinal cord. So we can see the trigeminal nerve exits the brainstem, travels through what's called the prepontine cistern, which is full of fluid, and enters Meckel's cave here, which is an anatomic structure. And from Meckel's cave, the nerve branches into the 3 branches, the V1, V2, and V3 branches, to supply the face, the cheek, and the chin. And so on this treatment plan, we have outlined in red, it's a like red rectangle, the area of the nerve that we will be delivering radiation to. And these color-coded lines represent the isocenter lines around the actual nerve. They show us the various different doses of radiation as we extend further out from the actual nerve. This is what a full treatment planning screen looks like on our system. So again, this is the view of the trigeminal nerve. This is on the left side. We've outlined the nerve with a contour, and then the program has generated the actual dose of radiation. These other 2 views in the lower left and right-hand views are additional views. This is called a coronal view. It's a vertical view. Here's the trigeminal nerve, and this is a sagittal view. It's a profile view. We can see the trigeminal nerve there. And this image in the upper left-hand corner, again, shows the various different beams coming in from many different angles, all combining to deliver radiation to the trigeminal nerve. In this case, we see the majority of the beams coming in from the left side because we are treating a left trigeminal nerve. And there's very few beams coming in from the right side because those radiation beams would have to traverse more brain tissue to get to the actual trigeminal nerve. So we've been treating trigeminal neuralgia at our institution since the early 1990s. We initially used a frame-based linear accelerator system similar to the gamma knife, where we placed a metal frame on the patient's head and targeted the radiation that way. But from approximately the year 2000, we started treating patients with trigeminal neuralgia using the frameless CyberKnife. We've had a variety of publications over the years from our institution at Stanford. I've also worked with other CyberKnife institutions around the world. The use of radiosurgery to treat trigeminal neuralgia is not just within the US, but it's an international treatment option for patients. And this was a group of neurosurgeons from Taiwan, which I worked with to deliver radiosurgery for trigeminal neuralgia patients in their country. We've also published a series of publications that are multi-institutional studies, and these are studies that focus on the treatment of trigeminal neuralgia with radiosurgery, combining results from several different institutions. This was a paper that we combined our Stanford experience with the Rocky Mountain CyberKnife and from a CyberKnife institution in Milan, Italy. And by combining data, we accrue larger numbers of patients, and we can identify results more conclusively. So in this multi-institution data here, we can see kind of some key patient demographics. We see in this particular study, there was a little bit more women than men. We can see the age was averaged about 70 years of age, ranging from 40 to 92. The duration of pain prior to treatment was 8.4 years. We can see the earliest patient treated was treated only after having about three months of pain, but one of the patients had 30 years of pain prior to treatment. We can see the laterality here in this particular study. We had more patients with right-sided trigeminal neuralgia. And then last, we can see kind of the distribution of pain. So the V1 distribution is pain in the forehead, and it's very unusual to have pain just in that region. V2 is the region around the cheek next to the nose, and V3, I like to explain it as along the jawline. So you can see the trigeminal neuralgia is much more common in the V2 and V3 distributions. And the most common presentation is to have it actually in both the V2 and V3 distributions. In this particular study of patients that underwent radiation treatment for trigeminal neuralgia, approximately 1/3 of the patients had previous surgical procedures such as microvascular decompressions, and then had recurrence of pain and therefore were referred for stereotactic radiosurgery. Let's talk about the results of radiosurgery for trigeminal neuralgia. So overall, initially, if we look at patients in the first 6 months, a good 80 to 90% have some improvement in pain, meaning the radiation damages the pain fibers, and the patient is able to either completely get off their pain medicine or use a substantially lower amount of pain medicine. As we follow the patients out further, we see a reduction in the response rate. We see that only about 50 to 60% of patients will still have pain relief in the long run. And patients often ask me why this is the case, and I think the simplest way to explain this concept is that the radiation is creating an injury to the nerve by damaging the pain fibers, and your body doesn't understand that this injury is being done for a beneficial reason. It thinks the injury is being done like any other injury in the body, and the body feels its job is to repair the damage. And so over time, your body tries to repair the damage to the pain fibers that was generated by the radiation treatment. And if it is able to successfully repair the damage, then those pain fibers can get reconnected and you can have recurrence of the pain. So that's why there's this drop off between the initial pain response and the long-term pain response. Now, if a patient has recurrence of pain after their radiosurgery treatment, you can consider a second course of stereotactic radiosurgery, or you can consider one of the other treatment options, such as a rhizotomy or a microvascular decompression. So overall, let's talk about the results of radiosurgery for trigeminal neuralgia. If you select the patients correctly, meaning you select patients that have that actually have classic or true trigeminal neuralgia, the type 1, type 2 trigeminal neuralgia, not other types of facial pain, you generally can have initial results in about 85 to 90% of patients. And this is, sounds like it's a great response. there's some caveats to this. First, the radiation can take a few weeks to months to work, and that's because the biologic impact of the radiation on the nerve can take some time to kick in. Interestingly, this response rate has been highly variable. Some patients have pain relief within a few days of treatment, and other patients it takes a number of months for it to actually kick in. We don't consider a radiosurgery treatment to fail in terms of treating trigeminal neuralgia unless at least 6 months have passed without any kind of response. The other factor to consider is that the radiation may completely eliminate the pain, allowing the patients to get off of all their trigeminal neuralgia pain medicine. And obviously this is the goal, because the medicines either are not working or are creating side effects. However, in a smaller subset of patients that have a response, the pain is either eliminated or improved, but the patient still requires a low dose of medication to maintain this response. And you can't tell when you deliver radiosurgery which of these categories the patient will fall into. I typically wait until the patient says, I'm not having any more pain after the radiation treatment, and then I will try to take them off their trigeminal neuralgia medications. We typically taper these medications, so it's not a sudden stopping of the medications. And if they're on multiple medications, I will usually stop one medicine first, tapering that first medication, and then work on tapering the second medication. In terms of choice of tapering, I usually taper the medication that I think is creating the greatest side effect to the patients in terms of drowsiness or cognitive issues, and then work my way to medications that I think have less side effects. I did mention previously that pain can return after radiosurgical treatment for trigeminal neuralgia, and this is, again, conceptually related to the healing of the nerve. In this case, you can consider retreatment with a second course of radiosurgery. And I want to talk a little bit about what that would entail. It typically involves exact same process as a first-time treatment for trigeminal neuralgia, but I will counsel the patient on the expectations are slightly different. When you treat a nerve a second time with radiation treatment, we typically don't see as good results as we do the first time. I typically will counsel a patient on expecting about a 75% response rate with a second treatment. And the second treatment can have more side effects that I'll discuss in another slide. So let's talk now about the possible side effects of radiosurgery. The most important side effect that we can see when you deliver the radiation for trigeminal neuralgia is facial numbness. And this is, again, because the actual trigeminal nerve carries both sensory and pain fibers, and we're not able to separate them out. They run together. You cannot target just pain fibers and not sensory fibers. Now, the pain fibers tend to be smaller fibers, and they tend to have a more aggressive response in terms of being impacted by the radiation than the sensory fibers. The sensory fibers tend to be larger when we don't see quite as strong impact, and we're hoping to get that the result of where the pain fibers are impacted and the pain goes away, but the sensory fibers are not. However, in approximately 25% of patients, the pain fibers are impacted, but the sensory fibers are also impacted. And this can create some numbness in the face, generally in the region where the patient has pain. And I think this is an important side effect to counsel patients on, because in the midst of severe trigeminal neuralgia pain attacks, most patients will say that they will easily accept some numbness in exchange for getting rid of the pain. However, I found that once the pain is gone and the patient is experiencing some of the numbness, then they really kind of forget how bad the pain is, and they can comment on how the numbness can impact them. Now, what I've also noticed is that patients that have numbness are more likely to have long-term pain relief from radiosurgery for trigeminal neuralgia. And why would that be the case? My thought process is that nerves that are more significantly impacted, they feel the effects of the radiation stronger, are more likely to have numbness, but are more likely to have the pain fibers have the inability to heal. Patients that have no numbness, the concept is the radiation perhaps didn't impact the nerve as much as it could have, and the pain fibers in those patients are more likely to potentially regenerate and heal. It's important to comment that the numbness may not occur right away, but can occur months later. So we typically don't see the numbness kick in for 6 months or more after the treatment in the 25% of patients that do have this numbness. And if it does occur, it could be temporary, it could improve over time, or it could be permanent. There are other rare side effects that can occur, and one is numbness around the eye. This is the same issue that I just discussed, the loss of sensory fibers in the trigeminal nerve. But if the eye becomes numb, then you don't feel things like an eyelash in the eye or a speck of dust in your eye. And if the eye is perpetually numb, it just requires a lot more monitoring of the eye health to make sure that you're not injuring the eye by having debris in the eye that you're not noticing. I think the most concerning side effect, although it is extremely rare, is something called anesthesia dolorosa. And this is a situation where the trigeminal pain is eliminated by the radiosurgery treatment, but a different type of pain develops. And this is a more burning, dysesthetic type of pain. It doesn't typically respond to the trigeminal neuralgia medications, and it's a much more kind of constant type of pain than the lancinating electrical shock-like pain that we see with trigeminal neuralgia. So this fortunately only happens about 1% of the time following radiosurgery, and the thought process is that the damaged pain fibers that are trying to heal just heal incorrectly, and it creates a different type of pain. It's also thought to be that your higher brain is interpreting the pain signals differently than before, and that's leading to this type of anesthesia dolorosa pain. But again, fortunately, this is quite rare. So who can be treated with CyberKnife radiosurgery? I think there's different categories of patients. I do want to say that certainly in my practice, if a patient has an MRI scan that shows a vascular compression and they're relatively young, meaning they have a decade or more of life expectancy, I typically recommend a microvascular decompression. I think that's a more durable treatment. It actually deals with the root cause of the problem in most cases, which is a blood vessel pushing on the trigeminal nerve. And I think it just gives you better long-term control as well as immediate pain relief. However, there are some patients that just can't undergo surgery. Either they have a significant number of medical comorbidities that prevent surgery. A common example is a patient's on blood thinning medication because of a prior stroke or a blood clot, and they really can't come off the blood thinning medication. There are some patients that because of heart disease or lung disease cannot tolerate a general anesthesia, and so those patients would be good candidates for the radiation treatment. The next group of patients that are good candidates, assuming they can't undergo microvascular decompression, are those patients that have not been able to tolerate medical therapy. So if you are a patient in which medications are still working and you're not having many side effects, or you're having no side effects from the medications, then we typically still recommend staying on the medications. And the reason for that is medications can often work for a long period of time before they fail, and we would only consider a procedure once the medications fail. However, in some patients, either the medications are no longer working, and you've tried multiple medications and they're no longer working, or the medications are creating too many significant side effects. And the main side effect is kind of drowsiness, slowed cognition, inability to focus. If you're kind of falling into that category and you're not able to tolerate a microvascular decompression, you're a good candidate for radiosurgical treatment. And then the last comment I want to make is that similar to a microvascular decompression, the radiosurgery is best used for patients with type 1 or type 2 trigeminal neuralgia, which in the older nomenclature would be the classic trigeminal neuralgia. That's a lancinating electrical shock-like pain. The radiation is not good for facial pain that falls outside of this category. So if I see a patient in clinic who comes in with chronic, constant burning pain, and they have no component of the sharp electrical shock-like pain, those patients are not good candidates for radiosurgery for two reasons. One is that the radiation typically doesn't improve that type of pain. And the second reason is that patients that have that type of burning, constant pain are at greater risk of having the pain either not get better or worsen with radiation treatment. So we really try to focus on those patients that have the true classic trigeminal neuralgia, the sharp electrical shocks that come and go. So to summarize, radiosurgery is a safe and effective mode of therapy for trigeminal neuralgia. I still feel that in patients that can undergo microvascular decompression, that's the preferred treatment because of the durability of the response. But radiosurgery can be used in patients who are not candidates for surgery. The initial results for radiosurgery, as long as you select the candidates appropriately, show that up to 90% of patients can achieve complete or partial pain relief. But this pain relief over time can diminish as the pain fibers in the trigeminal nerve heal. And generally, I tell patients that I use a 50% at 5-year rule, that at 5 years after radiosurgery, 50% of the patients will still have pain relief, and the other 50% will have some recurrence of pain. The effective latency, what we call the time period to pain relief after radiation treatment, can vary anywhere from a few days to a few months. And we typically will wait at least 6 months after radiation to see the full effect of radiation. So if you've gone 6 months since the radiation and you've had no benefit, we consider that a treatment failure. Numbness in the face is the main side effect. And again, most patients would gladly trade numbness if they could get rid of the pain. But we always like to present this to patients as a possible side effect. And this is one of the differences between the radiosurgery and a microvascular decompression, in that the risk of numbness after microvascular decompression is much lower than it is after radiation. And so finally, radiosurgery can be an initial treatment option for patients that have failed other options, such as a microvascular decompression, or in some instances, it can be the upfront treatment in patients that have comorbidities that preclude them from undergoing different types of procedures. So I wanted to conclude there and then switch now into a short question and answer session to go over the common questions that I typically see in clinic when talking about radiosurgery. Before we get to that, I want to just show that I'm going to acknowledge all my co-workers at Stanford on the radiosurgery program. Radiosurgery is a team event and involves radiation oncologists as well as neurosurgeons, nurse practitioners, nurse coordinators, schedulers, and medical physicists, all of which work tirelessly to take care of the patients.
Thank you, Dr. Chang, for your wonderful presentation. Here are some of the frequently asked questions. So when should a patient consider radiosurgery versus a microvascular decompression?
Yeah, this is probably the most common question that a patient with trigeminal neuralgia has when presenting to my clinic. And part of the challenge is that there's when we talk about treatment options, there's an abundance of procedures. And I've always thought that, when we have more procedures that are available to patients, on one hand, that's good, but on the other hand, it can be confusing for the patients. And so radiosurgery and microvascular decompression are two of the most common procedures for trigeminal neuralgia. And so it's very common for patients to be thinking about those two procedures when they're coming to clinic. Generally, I break it down this way. If a patient has an MRI scan that shows blood vessel compressing the nerve, that implies that the patient has an actual anatomic problem for their face pain. If they're a younger patient, and by younger, I don't define that really by chronologic age anymore. I define it by how many additional years or decades of survival they will have after their treatment. Then if that's a substantial period, then I favor microvascular decompression, because that's a more durable treatment, meaning if you have complete pain relief after microvascular decompression, it tends for the most part to be lifetime treatment. And the microvascular decompression is the treatment that actually deals with the root cause of the problem, which is the blood vessel pushing on the nerve. Radiosurgery is attractive because it avoids an operation. It's an outpatient, non-invasive treatment, and it initially gives you the same 85 to 90% of success as a microvascular decompression, but there's a more rapid fall off over time. And I mentioned that 50% at 5 years. So 5 years after radiosurgery treatment for trigeminal neuralgia, pain is recurred in about 50% of patients, and the other 50% have maintained their pain control, whereas the microvascular decompression group has a much higher percentage of patients that are having long-term pain. So it's a little bit of a trade-off here. If you take a non-invasive treatment up front, you're more likely to have recurrence of pain. If you take the microvascular decompression, which is a surgical treatment up front, you're more likely to have long-term pain relief. I think the estimated survival of the patient is important, because if a patient has other medical issues and we think that they are not going to have several decades of life in front of them, but just several years, or 5 years, then radiosurgery may be a great option to achieve pain relief over that period of time.
Thank you, Dr. Chang. Why can it take months for the radiosurgery to reduce the pain?
That's a biologic question that is not quite fully well understood. We know from animal models, including in other primates, that the radiation can damage the neurons, and we can study those under microscopy. We can see the injury to the nerves, but the actual physiologic impact in eliminating the pain is still somewhat highly variable. And we've seen patients that have had pain for years and years and years get the radiation treatment, and within a few days are expressing dramatic improvement in pain. And at the neurologic level, the radiation would not have had a time to damage the nerve yet. So that's a little bit hard to explain. Alternatively, you can have patients that same age, same type of pain and whatnot, and one can have pain relief after just a few days, and others can take months for pain relief. So I think there's a number of factors. We don't quite always understand them. Certainly, we know factors such as the dose of radiation are somewhat important, but even then, there's factors that vary from patient to patient that we can't fully explain. But again, we will say it can take up to 6 months to achieve pain relief, and most, I would say, the average patient achieves it in about 3 to 4 weeks, but in a few outliers can take several months.
Should I be concerned with facial numbness after radiosurgery?
So this is the double-edged sword when it comes to radiosurgery for trigeminal neuralgia. And I want to kind of make two comments on this. The first is when patients are expressing severe attacks of pain, almost every patient will gladly trade pain for numbness. And as a result of a successful treatment where you eliminate the pain, if the patient then has numbness, they may feel they've not had a perfect response to the treatment. The pain's gone, but now they have some numbness. The numbness can cause patients to, you bite inside your cheek a little bit more, or if when they shave, they're more likely to nick themselves. So the numbness can be occasionally bothersome. Most patients that have it are very accepting of it, given that they don't have pain if the treatments are successful. But I think the further out you get from treatment with complete pain relief, the more the patients are less likely to remember the pain, and they sometimes more comment on the numbness. The second issue I want to mention with this, and I mentioned it earlier in my presentation, is that those patients that have pain relief and some facial numbness, at least in my experience, are more likely to have long-term pain relief than patients that don't have facial numbness. And I use facial numbness as a measure of how well the nerve has been impacted by the radiation. If the nerve has been impacted heavily and the patient has some numbness, much less likely that the pain will recur. If the patient has pain relief but no facial numbness, more likely that the pain will recur down the line. So to some extent, if you don't have numbness, that may be great, but that may be more likely that you're going to have a recurrence of pain than someone that does have facial numbness.
Okay, thank you, Dr. Chang. So here's another question. Why does trigeminal neuralgia come back in some patients who have had radiosurgery?
And again, this is, we don't kind of fully understand this on a biologic effect. Simplistically, it's, in my mind, it's always been the nerves trying to heal. I've always wished that there was some way we could tell the human body when we do radiosurgery for trigeminal neuralgia that this is a good injury don't repair it. We're doing this for a specific reason, but the human body doesn't understand that, and so we're left with a situation where the body does what it normally does when it sees injury. It tries to repair it, and this reparative mechanism starts literally right away after the radiation treatment. So you deliver the radiation to the nerve, and the body starts trying to repair the damage. Sometimes it takes years to get the pain fibers reconnected, and other times it never gets reconnected. We certainly have patients that are decades out from radiosurgery that still have complete pain relief. But it's basically the body's reparative mechanism that causes the pain to come back.
Can radiosurgery be repeated a second time if the pain returns? What are the risks of a second treatment?
So we can certainly repeat radiosurgery a second time if pain returns. And in fact, all the procedural treatments for trigeminal neuralgia could potentially be repeated. You could repeat a radiofrequency rhizotomy in certain cases. And in other cases, you can even consider a repeat of a microvascular decompression. So you can repeat radiosurgery a second time. And this scenario where this happens, there's kind of two scenarios where it happens. The first is where a patient has excellent pain relief for 5 years, 10 years, and the pain comes back, and they had that window of time where they had pain relief, and they want to get another chunk of time where they have pain relief. And a second situation where we consider repeat radiosurgery would be is when we deliver the radiation, we follow the patients for the first 6 months, they've not had any pain relief, and then we consider radiation a second time. So the risks of a second treatment are a little bit different than the risks of the first treatment. The risk of numbness is higher, because if a patient is being treated with a second course of radiation, the nerve is essentially being damaged twice. And those sensory fibers that control the feeling and the temperature and the light touch of the face are going to now be hit with a second course of radiation. And that damage can cause the sensory fibers to be more dramatically impacted. So I always counsel patients that the risk of numbness is higher with the second course of radiation. The second issue, it's not really a risk, but it's an expectation, is that the pain relief is not quite as good. So I typically quote 85, 90% the first time around. The second time around, we're down to 70, 75%. And that's because essentially, if you're doing a second course of radiosurgery, you're selecting out patients that, for reasons that may not be fully clear to us, that are more resistant to radiation. We call it biologic radiation resistance. And it's in this selection bias accounts for in my view, the reason why the success rates are lower the second time.
Next slide, I see. What patients are not ideal candidates for radiosurgery?
So this is an excellent question, because there are several different categories of patients that are not ideal candidates for radiosurgery. The first broad category would be patients that don't have the classic trigeminal neuralgia, the sharp electrical shock-like pain. I mentioned patients that have just dull, achy, chronic pain without the sharp electrical shock-like pain are not good candidates for radiosurgery, just because we know that the radiation just doesn't work well in those patients. So those patients would not be ideal candidates for radiosurgery. Sometimes, in rare occasions, when we do an MRI scan, we see some structural issue, like a large brain tumor that's pushing on the trigeminal nerve, and you really need to do surgery to get the nerve decompressed. Those candidates would not be great for radiosurgery. And then I do think that, particularly candidates where we think that they have a long period of expected survival are probably better treated with a microvascular decompression. And so if you have a patient who's 30 years old and they have an MRI scan that shows a vascular loop compressing on their trigeminal nerve, that patient may have 6 or 7 decades of life in front of them. And if you are going to pursue a radiation treatment that has a certain probability of the nerve recovering and healing, that may not be the best option for the patient. The younger the patient is and the more years of expected survival, the more durable we want treatment. We want a treatment to last 60, 70 years. And that tends to be more likely to be a microvascular decompression than radiosurgery. Now, radiosurgery is good for patients with a life expectancy that is not quite as long. It's good for patients that have medical comorbidities and cannot tolerate microvascular decompression. In some situations, the patient's a candidate for both. And in my practice, I typically present both options to the patient and go over the pros and cons of each, because both are standard of care and ultimately the patient has to decide.
Why do I need an MRI scan if I am undergoing radiosurgery?
So that's a good question, because a lot of times patients have this concept that we're doing an MRI scan because we want to see if you have a blood vessel pushing on the nerve so we can do a microvascular decompression. And the minute you say we're going to do radiosurgery, the patients, they think, well, good, I'm off the hook for the MRI scan. You know, some patients are claustrophobic. The MRI scans are hour long in a narrow tube. But we use the MRI scan in radiosurgery to target the radiation. And the nerve is very small. The nerve is about 1/4 inch by about 1/2 inch. And so in order to precisely deliver the radiation to the nerve, we need to be able to see the nerve with a lot of detail. And so that's why we like to do these MRI scans. And it needs to be a special thin slice MRI scan. There's certain sequences that we use. We use a Fiesta sequence on a GE scanner. We use a CIS sequence on a Siemens scanner. And unfortunately, a lot of patients come in with an MRI scan that does not have these thin slices on them, and we end up having to repeat the MRI scan prior to the radiation treatment.
If I have radiosurgery and my pain recurs later, can I have a microvascular decompression? Are there any issues to be aware of when considering a microvascular decompression after radiosurgery?
Yeah, this is also an excellent question, because this question is typically asked for by patients that have already had the radiosurgery treatment and the pain is coming back. And so now we're back in clinic and we're having a discussion now. So the patient went with the non-invasive route first, got some pain relief for, let's say, 5 years, 10 years. Now the pain comes back. And now we're talking about how a second course of radiosurgery may have more numbness, may have a less efficacy, and the MRI scan may still show a blood vessel pushing on the nerve. And you know, these patients are still good candidates for microvascular decompression. Sometimes you know, the kind of the loss of an ability to do more radiation treatment will direct the patient toward a microvascular decompression. Sometimes they just basically want a more durable treatment after experiencing kind of a more transient response with the radiation. But you can certainly do a microvascular decompression as long as the MRI scan shows a blood vessel compromising the nerve. In terms of issues to be aware of, the radiation, if you've had prior radiation to the trigeminal nerve, it can injure the nerve and make it appear thinner. There can occasionally be a little bit of more scar tissue down along the nerve where the blood vessels in contact with the nerve as a result of the prior radiation. But generally, in my experience, I've not found that a microvascular decompression is any more challenging after radiosurgery than it would be if that was the upfront treatment.
Okay. Should radiosurgery be considered a first line of procedure after medication failure for trigeminal neuralgia?
That's a question. I think it's a good question. So it's somewhat controversial depending upon who you talk to. And again, I've stated before in this presentation that I personally consider the microvascular decompression to be a better first line procedure in younger patients. In patients that have comorbidities or can't tolerate a general anesthetic, radiosurgery can be a first-line procedure. I think it's important to emphasize the expectations of the potential recurrence of pain down the line and the numbness that can occur in the face as a result of the radiation treatment. But assuming the expectations are understood by the patient, radiosurgery can be considered a first-line procedure after medication failure. So again, those are the most common questions. If you have any additional questions that I wasn't able to answer, please feel free to either call or email me. I'd be happy to answer anybody that asks questions. I do want to again thank everybody for their attention this morning during this presentation, and I also want to again acknowledge the Facial Pain Association for their tireless and excellent work in putting on these educational programs for patients, as all of us strive to eliminate facial pain in as many patients as possible. Thank you for your time, everybody. Have a good rest of the day.